Good morning. This is Lisa McBride, professor of NUR 160. I'm coming to you today to um, present on week 7, day 2 gas exchange. Hopefully, you're able to see my screen right now. And please make certain that you have the correct SharePoint presentation on gas exchange. We'll be going over Giddens chapters 19 for respiration and combining the two processes, external respiration and internal respiration. So, external respiration occurs in 4 ways: ventilation, which is the mechanical movement of air in and out of the lungs, disbursement of air throughout the bronchial tree of the lungs, diffusion of oxygen and carbon dioxide molecules across the alveolar membrane, and then, of course, perfusion, the movement of blood through the lungs and tissues, which we'll be covering in next week's lecture. Make sure that you also obtain those lectures off of your SharePoint so that you have those. Uh, so let's go on. Internal respiration, of course, happens at the cellular level. Oxygen, which is inhaled through our nares into our lungs, is then absorbed through our alveoli and capillary bed, then transfers that particular oxygen to the hemoglobin, to the cell, and then, of course, it gets dispersed through our lungs, through our body. Because adequate gas exchange is required for life, all individuals, regardless of age, race, or socioeconomic status, are potentially at risk of gas exchange impairment. So, what is gas exchange impairment? That, of course, is the ability not to breathe very well. That means that we're not either taking in oxygen well enough, or we're not able to transfer it because of blockage like COPD or some other structure issues with the lungs. It could be through cystic fibrosis, which we don't hear of too much these days, or some type of sarcoidosis or other illness, pneumonia, etc. Some of these risk factors are controllable due to lifestyle behaviors such as smoking, but others are not because it is part of the illness or part of the other genetic factors. Because adequate gas exchange is required, then we need to make certain that we recognize that some individuals are at greater risk for impairment, whereas others may not be. It is important for patients to be educated on diet, exercise, of course, quit smoking, exposures to respiratory irritants and inhalants to make sure that they avoid those. If they work in factories or businesses that have aerosols or some type of contamination that's in the air, that they need to make certain that they are wearing appropriate masks and aerators according to their OSHA policy at their work. And then, of course, patients may have allergies or current medications that are also responsible for their airway. Acute illnesses such as asthma and pneumonia, and again, COPD, can all lead to impairment. Conditions that specifically involve gas exchange, including conditions of neurologic issues, such as that of the brain or the spinal cord, and of course cardiovascular. That's our heart. If our heart's not working correctly or well, and we don't have enough blood flow to our body systems, then we're not going to be able to get enough oxygen to our end tissues. These body system problems can arise from genetic conditions or congenital defects. It can be caused by injury, inflammations, and of course, cancer. The 3 broad categories that represent problems associated with the concept are ventilation, transport, and then, of course, perfusion. Ventilation is the act of breathing in. Transport is taking that oxygen and transporting it to the system. And perfusion is the end product of getting the blood, hemoglobin, and gas oxygen to our end stage tissues. So, what are age-related risk factors? The populations at greatest risk for impairment of their uh, respiratory system is, of course, infants, young children, and older adults. Those are the three that we talk about quite often. Infants are at risk because they have fetal hemoglobin. Fetal hemoglobin is present for the first 5 months of life and results in shortened survival of erythrocytes, which causes a physiological anemia by age 2 or 3 months, meaning that they have been dependent on mother's system to produce all their blood and produce all their, take care of their wastes and their feeding and nutrition and their breathing and oxygen exchange. And now suddenly it's their body's charge to do that. Normal erythrocytes live for 120 days. But in infants, they, of course, have a shorter duration because their system is slow in getting up to the production they need. By 6 months, hopefully, they've had that all taken care of, and then we don't see that issue any longer for them. Older adults are at risk for impaired gas exchange because of anatomic and physiological changes that occur with advanced age. The chest wall is stiffer, it's less elastic, it doesn't recoil as well. The diaphragm and muscle, which is a muscle, may not work as well. It reduces the effectiveness of coughing, which is a normal and protective mechanism to keep us from aspiration and to also keep our lungs clear. Additional expected changes are dilation of the alveoli, decreased surface area of gas diffusion, and decreased pulmonary capillary network. Finally, the ability to initiate an immune response to infection is decreased with older adults. Personal factors. Hey, we've got a lot of different things that go on with our gas exchange. The non-modifiable risk factors include age, again, and of course, populations at risk, they live in the inner city or closer to air pollution and allergies. Tobacco use, of course, is the single most preventable cause of death and disease in the United States is the most significant risk factor for impaired gas exchange. So let me again say tobacco, tobacco, tobacco. Need to stop that stuff. Risk for aspiration, of course, is increased with older adults because of altered state of consciousness. That can be from chemical alterations, especially if that patient has a history of alcoholism, drug overdose, and if they've had anesthesia, like for surgery. If they've had a neurologic disorder, such as a head injury, seizure, and stroke, then they're going to be at a greater risk as well. And if they are a patient that has required tracheal intubation, they're at risk because their normal protective mechanisms are bypassed. We are putting air directly in through the trachea into the lungs with ventilation, and that also causes us to have them on prolonged bed rest, which, of course, as we know, increases their immobility, which increases their risk for atelectasis and pneumonia. Atelectasis is the process of the lungs being in a collapsed state. Pneumonia, of course, fills up with all types of debris and purulent infection in the lungs, not allowing the alveoli to actually do its job or the lungs to do its job. Chronic diseases, as I mentioned earlier, the cystic fibrosis, COPD, and heart failure increase our risk of mucus and fluid accumulation, which alters the body. And then, of course, there's other systemic disorders such as aplastic anemia, cancer, leukemia, and other treatment regimens such as cancer therapy, chemotherapy, and other things can affect multiple systems as well. So let's review the changes in the older affecting respirations. Okay. Okay. Hmm. So what changes do occur in vital signs with aging? So as we watch our vital signs, they become less reliable indicators of health in the older adult. Our patients who are older, they don't typically have a fever, or they're harder to develop a fever. Most of the thermo regulation that they have is going to be a temperature that's in the 97s instead of the 98.6 as we call normal. And this is usually due to a lower metabolic rate. The normal range for heart rate also changes as we get older, but the rhythm might be slightly irregular. Again, the heart rate doesn't change, but the rhythm may. Rest unless they're on meds. Let me give you that caveat. If they're on new medications such as our beta blockers, our calcium channel blockers, they're going to be a little bit more depressed with their heart rate. Respiratory rate may rise as decreases in vital capacity and respiratory reserve occur. Our systolic blood pressure rises slightly because of, again, the arteries lose their elasticity with age. In older adults, the diastolic pressure rises also. So we may see more normal blood pressures in that age group in the higher 80s for diastolic and the 130s for systolic. After age 70, there is a decrease in elasticity of the thorax, meaning the rib cage, because of the respiratory tissues become a little bit more stiffened. Total body water also decreases by 50% after age 70, leading to dry respiratory membranes and thicker mucus. The cilia, which is the hairs that are inside the respiratory system, may become impaired, and they don't do their job as effective to remove mucus and foreign material. And of course, the loss of elastic recoil, which means that the muscles have to be used to complete expiration. So as we watch our patient breathe, watch them to see if they're using their accessory muscles, see if there is depression of those muscles and increase around the rib cages. That's what we're looking for. Oxygen saturation decreases with partial pressure of oxygen dropping to the 75 to 80 millimeters of mercury from the usual 80 to 100. And of course, the older adult has less respiratory reserve, which means it's making it harder for them to meet their needs of their metabolism and their body. So, what information is important to collect? What are we going to look at? Of course, when we're doing our baseline history, we're going to get subjective data from patients. Make sure that you ask about their tobacco use and exercise and diet. We should also ask them about their work environment and their home environment to see if they're not the smoker, is there anyone else in the house that smokes? Is there anyone else that does woodwork, or are they in paint factory? Do they work in a auto factory where there's a lot of boring of metal materials and possibility with oils and smokes and things of that sort? Do they work in a kitchen where there's a lot of frying going on in a cafeteria or a restaurant? Do they have chronic diseases or allergies that affect their respiratory system? So we need to be asking them about their, again, medications and their over-the-counter medications and the reason that they take each of those medications, as well as are they working? We need to also take a problem-based history. A lot of times our patients are telling us they have a cough or shortness of breath or chest pain with breathing. Then we need to be able to take that data and transfer it so that we can analyze that. Is the cough that they report, is it dry? Does it produce mucus? Do they have fatigue that interferes with their sleep? The patient also should be asked if the cough hurts. Do they have a production of sputum with that as of a persistent color? Is it always green? Is it always yellow? Is it brown tinged? Is it red tinged? Those are things that we need to ask. What do they do to alleviate the cough, or is the cough always there? Has it always been there? When did it start? Has it been more than 6 months? Do they have a cough that just continues to nag and doesn't seem to have any reason for it at all? Of course, we know that that's one of our signs that they may be having some type of lung cancer, or throat cancer. We need to make sure we check that out. Also, the patient should be asked about other symptoms that accompany the cough, such as fever or shortness of breath. If they are having shortness of breath, especially if to catch their breath. For instance, they take 2 or 3 steps up the stairs and they have to stop, or they walk across the floor or try to do some housework and they have to stop in between. Are they having to use several pillows? That's an important question, especially for our COPD patients as well as our congestive heart failure patients. How many pillows are they using at night? Are they having to sit up in a sitting position in order to sleep? Are they actually sleeping in a recliner? And is it because if they lay flat, do they have difficulty breathing? So that would be called P&D, which is post-nocturnal dyspnea. We need to know about that. Again, stress that with your COPD and your congestive heart failure patients. Those are good signs that tell us whether or not that patient is functioning well. If they cannot sleep flat, then we know they are having some issues. And how chronic are they? There are other symptoms that we need to be looking for as well. Besides the cough and chest pain, do they have swelling of their feet and ankles? Is there a fluid balance issue? So our nursing assessment, again, we're going to be getting a lot of data. Is their breathing quiet and effortless as we listen? Um, can they do pursed, or are they doing pursed lip breathing? Sometimes patients will do pursed lip breathing if they have COPD that's really bad and they're trying to increase the exhalation because they're air trapping with their COPD, meaning they're trapping the CO2. Breathing should be quiet and effortless. Oxygen saturation should be 95% to 100%. Our COPDers probably are going to be more around the 90 to 92%. It's whatever is normal for them, but according to our text, we need to be able to say, yes, they're above 95%. Are the skin and nail beds, is the skin nice and pink? Is the nail beds or capillary refill brisk? Is it less than 3 seconds? Do they have clubbing of the fingers? Are the lips the appropriate color for their race? Some patients that have issues with respiration, their lips will be on the purplish side. Is their thorax, their rib cage, is it equal? Does it expand bilaterally? Sometimes putting your hands on both sides of their rib cage and having them take a deep breath, you can feel if there's any rumble. You can check the expansion of the rib cage. Do they have spinous processes that are in alignment? Are they symmetrical? Is the diameter of the chest in the top half and the bottom half equal? Is the front to the back equal? Look for a barrel chest, a chest that looks more like the shape of a barrel. That tells us that they have had COPD or a breathing problem for quite some time. The trachea should be midline. Breath sounds should again be clear bilaterally. Patients may be using a position that eases difficulty. Are they in a tripod position, sitting upward, leaning forward because they are anxious? Then, yeah, they're having difficulty breathing. Inadequate gas exchange causes changes in vital signs, such as increase in respiratory rates. So, our respiratory rates that are in the 25s or 24, 25, 26 may indicate that this person is dyspneic. Above 30, yes, they're tachypnic. That means they are breathing far too quickly. As gas exchange it worsens, then of course their oxygen saturation is going to drop below 95%. They may become tachycardic as the heart tries to balance out that um, respiratory rate, and of course that can occur from anxiety. That's a compensatory effort to increase the perfusion, so our heart kicks in order to balance. Temperature then may be elevated because of the extra work, or they may be elevated slightly because they have an infection or pneumonia. But again, remember the older adult may not have the same height of fever that a normal adult would have. They may have their temperature may only register in the 99s, not quite into the hundreds. So any type of increase from their normal baseline is to be concerning. So again, assess the patient's gas exchange, look at their CO2, um, interact with them, see if they can talk without having to gasp for air. If they are using their accessory muscles, again, to inspire to help get air into the lungs or help get air out of the lungs with pursed lip breathing, those are all signs for us to note that, yes, this person is having difficulty. And again, emphysema and other conditions are going to cause worsening vital signs, and we're going to see our findings to be pretty drastic with them. So when we're listening, are we hearing wheezing? Is it expiratory or inspiratory? Are we hearing mucus move around with the rumble of bronchi? And are we hearing crackles with the alveoli as they're opening up? So those are all things that we need to be assessing for. Our interrelated concepts for respiratory and gas exchange, of course, include anxiety, acid-base balance, perfusion, fatigue, mobility, nutrition. All of these things affect this person. So we need to look at the acid-base balance. Again, we're learning about ABGs and learning how to look at those in lab. Um, we're going to be going over arterial blood gases and how to determine if it's respiratory acidosis or metabolic acidosis or alkalosis or respiratory alkalosis. So which system is causing the imbalance? Diseases that cause retention of carbon dioxide, such as COPD, those increase our levels of carbonic acid, and that causes respiratory acidosis. So as a patient holds on to CO2, they become more acidic. If they're blowing off CO2, then they become alkalinic, especially during panic attacks. If they're having hyperventilation, they're blowing off that CO2, so they're going to get alkalotic. So hypoxia is attributable to inadequate perfusion, again, from the heart. So if we've had a heart attack and there is lactic acid buildup from metabolic acidosis, then we expect that patient to be breathless, especially during things such as an asthma attack. They may experience anxiety due to the lack of oxygen. Not being able to breathe for COPDers, they get also very anxious as well. And if they have congestive heart failure, and because of the load that's being put on their lungs and their heart, they too will experience anxiety. When patients have gas exchange, they become very short of breath or dyspneic. They can't walk up a few flights of stairs. We can ask them, how far can you walk? Were you able, when you were coming into the office or coming into the facility, are you able to walk all the way in, or do you have to stop? That kind of tells us how bad their fatigue or how bad their gas exchange is. We need to also look at their blood levels. Are they anemic? If the person is anemic and severely anemic, if hemoglobin is below that 7.0 level, then we know that they're not going to have very good gas exchange. They're not going to, their respirations are going to be uh, pressed. They're going to have problems breathing. Nutrition is a concern, of course, because the patients who don't get enough nutrients, they're not going to be able to breathe as well. The cells are not going to be able to be replaced. Um, those that have emphysema or cystic fibrosis, they have an increased energy to breathe. They require high calorie, high protein, nutritious foods. And if they don't do that, then they get tired. Sometimes they get tired while eating, where they can't eat very much, and so they push away. So they are going to be malnourished. Patients with anemia need food high in iron to maintain or increase their hemoglobin levels. And if they can't do that, then we are doing iron infusions. There are multiple conditions or exemplars that contribute to impaired gas exchange. And we've talked about a number of these already. Again, it's asthma, COPD, lung cancer, pneumonia, some type of virus like coronavirus, anemia, pulmonary embolus, And then we're going to focus on anemia, asthma, COPD, and pneumonia because you'll be seeing that quite often in your clinical endeavors. So Williams page 455 to 456 covers acid-base balance. And again, that is very important in maintaining homeostasis in the body because cell enzymes can function only when a very narrow range of pH. pH is a measure of the degree to which a solution is acidic or alkaline. Our metabolism constantly produces carbon dioxide, which combines with water to form carbonic acid, which is the H2CO3 that we look at for blood gases. That immediately breaks down into hydrogen ions and bicarbonate ions. And again, hydrogen ions are the ones that cause our bodies to be acid. Bicarbonate ions, the HCO3, is what balances everything out. The concentration of hydrogen ions determines the pH. Our normal serum pH again is what? Do you recall what that is? 7.35, yeah, to 7.45. If the pH is below 6.8 or above 7.8, death may occur because of the production of acids by the body and the metabolic systems. The body tends to become acidic if homeostasis is upset. So we want to keep our body in the normal pH or more of an alkaline state. Bicarbonate is an important substance. That's that HCO3. It's normally 22 to 26 milliequivalents per liter, and it's the major function that controls the balance. It helps offset that CO2 that we have in our body and our H2, which is the hydrogen ions. It's a buffer. It neutralizes the excess acids. So for the body to maintain its bicarbonate to carbonic acid ratio, it should be at 20 to 1. 20 parts bicarbonate to every 1 part carbonic acid. And that is where we get our homeostasis. The kidneys need to reabsorb or excrete bicarbonate to regulate serum levels and help maintain acid-base balance. So our kidneys are very important in that ratio. Again, as you'll see in lab, as we study the blood gas, our kidneys not working with our lungs and our lungs not working to help can cause our body to be out of balance. Again, acid-base control mechanisms, it's all a balancing act. That's the core concept. If we can keep things in balance with HCO3 and CO2, then our pH is also in balance. If we can help, one will work towards evening out our pH. Again, the normal for pH is 7.35 to 7.45. And then the normal for CO2, PaCO2 is going to be 35 to 45. You just drop the sevens. And then you already have the base, the 22 to 26. So we keep those, memorize those, keep those in mind. So if our system is too much buffer, we have too many bases, we have too much bicarbonate in our system, and we don't have enough weak acid, then we can also become an alkalotic state. So our sodium bicarbonate, again, and carbonic acid buffer system needs to be in balance. When acid is added to the blood, it combines with the base bicarbonate to provide a buffer. And again, that causes us to be in balance. So again, our first control system is our gut. Our bowels help balance that. So we again have base in our bowels. We also then have the kidneys then doing its job by providing base and holding on or excreting the necessary components to keep our blood in balance as long as our kidneys are functioning well. And then our respiratory system will also try to get into the act. It will hold on to CO2 to increase the acid, or it will blow off CO2 like in hyperventilation in order to blow off CO2, which is alkalizing the body, getting rid of that CO2. The second control mechanism for pH, of course, like I said, is the lungs. That's where our CO2 is produced. The lungs can expel more carbon dioxide or conserve it to help balance that out. So we'll see patients again with hyperventilation, or they'll be breathing real slow. So that helps them to adjust. They go low and go slow. The third mechanism for pH, of course, is the urinary system. We've talked a little bit about that, the kidneys and enzymes. So know all three of those systems, which ones helps which one compensates for which. So here's our normal ABGs: pH 7.35 to 45, CO2 35 to 45. You can see that you just drop the 7, so you get your CO2s. PaO2, which is the partial pressure of oxygen, is usually 80 to 100 for normal adults. Of course, we talked about with aging, that might be a little bit lower for older adults. HCO3, that's our buffer, that's 22 to 26, and our oxygen saturation should be 95% or greater. That's what we're going by here with our text. So we have four different mechanisms that we need to be familiar with: respiratory acidosis, metabolic acidosis, respiratory alkalosis, and metabolic alkalosis. I want you guys to watch this YouTube on your own. It is in your handout, so make sure that you copy and paste that into YouTube to watch that. It will go over the four different types. You'll also see, I don't know if this is the same one that we used in lab recently. It possibly could be. No, that's a different presentation, a different one than what I am using in our lab. You're welcome to watch that. I would say there's like three or four of those pH or ABGs made simple. Um, Nurse Sarah is doing a couple of those, one on the tic-tac-toe, and then she has one on the Rome method. This one here is also one method. I also like looking at Simple Nursing, their marching band one, which it actually does a very good job with compensation. I'll also send that out to you. So let's discuss clinical and medical management of respiratory conditions. Again, we're going to be doing examination, evaluation, tracking, primary prevention, secondary prevention, and discussing collaborative interventions. Our clinical management related to gas exchange, of course, includes health promotion and management of emergent conditions that present themselves. The ultimate goal, of course, is to make sure that the patient is being able to breathe and that we're maintaining life. Remember Haslow's hierarchy needs and our ABCs. As long as we remember those, we should be able to choose the correct interventions. So our primary prevention includes measures to promote health, stopping smoking and preventing damage to the lungs. One of the simplest preventions, of course, is proper hand hygiene. That helps to reduce respiratory tract infections. Definitely all individuals need to be taught this, also to um, cough into their elbow, to cover their cough so that they're not spreading any type of viruses and contaminants in the air. Um, Making certain that our children also do that and wash their hands. Very important as we get older to make certain that of hand washing, and then of course that as you're shaking hands at church, or if you're around that type of milieu where you're in congregation with other people, keeping hands clean. Don't touch your face, don't touch your nose while you're after shaking hands. Wash your hands, have some hand gel. I know our church has got hand gel everywhere now to try to cut down on passing things along. We love to pass the love, but we also love to pass the viruses too. So we're trying to cut that down. Goals related to smoking cessation, not vaping, trying to decrease any type of inhalants that are hurtful. Of course, our work sites and restaurants have all gone to smoke free. A lot of our cities have gone to a smoke free in civic buildings, so that helps. Making certain that people get their immunizations, make sure that they're fully vaccinated for pneumonia. There is at age 65 where we tell our older adults to make sure that they get their pneumovax. If you have an immunocompromised disease like asthma, COPD, or you're younger, yes, you should get that pneumonia shot. We also encourage flu shots every year, and then to also keep up on our measles, pertussis, and rubella type shots. If you're going to go overseas, make sure you've caught up with any of your recommended vaccinations for the area that you're going to. That could include cholera, typhoid, yellow fever. So make sure that you're up to date. After surgical procedures, patients are encouraged, of course, to use the incentive spirometer every 2 hours, 10 times. And we need to be able to demonstrate that or explain to them how to do that. Um, we want them to deep breathe as much as possible to keep them from having pneumonia. We want them to start moving and to getting them up and ambulating to make sure that they don't develop any DVTs or PEs. We want them to use TED hose if they're still in bed, not moving as much, or using some type of support hose or some type of compression device that will keep the blood flowing. Our secondary preventions, of course, is screening. We're going to be looking at screening for early diagnosis and treatments of health problems to catch them and to get ahead of that. With our patients that go to nursing homes, we do a TB or Mantoux test in order to make certain that they don't have tuberculosis before they go into those, because we don't want to expose an entire facility. Um, Indiana had there for a long while not seen too much in the way of TB, but TB with a lot of immigration, other people coming from outside the country into the country, we've seen a rise in TB in our general populations. So again, talk about smoking cessation. We talk about that. That's our collaborative intervention. And vaping. I have to say vaping because smoking cessation isn't everything. A lot of people have gone to vaping, but vaping nicotine is still vaping nicotine. You're still putting something that's foreign. We do not know what that's going to cause. Pharmacotherapy plays a very important role. Again, in gas exchange, there's agents that help open our upper and lower airways to improve gas exchange, dilating the bronchioles, helping with that. That's our albuterols and our ipratropium bromides, our long-acting bronchodilators, and our short-acting bronchodilators. And then we have antihistamines that cuts down on sneezing, allergies, rhinitis, and helps to block our histamine to cause vasoconstriction and decreases our capillary permeability of small arterioles and venules. Decongestants relieve congestion in the passages and the sinuses, like Afrin, etc., but they should only be used for short term. Then there's glucocorticoids, which is an anti-inflammatory, such as Medrol dose packs, prednisones. We have the fluticasone, which are the inhaled steroids. Those all have uh, assistance in our airway patency, but they also come with those particular ones. Remember that we can see blood sugar issues with our steroids and prednisone, and with fluticasone, need to have that patient rinse and spit. Our glucocorticoids, those reduce our bronchial hyperactivity, and especially with asthma, and help shut down or decrease the release of leukotrienes, which causes us to have issues with our breathing. Um, They also decrease infiltration of cells such as eosinophils. Sometimes patients that have asthma, their eosinophils are a driver of those allergic reactions. So it's very important for us to note that because there is things like Dupixent and other drugs that help patients that have eosinophilic asthma. Those medications can be given orally or they can be by inhalation. Need to write these down, folks. I keep telling you, make sure you start using your 3x5 cards to make up your medications. And again, looking at these inhalations, the oral ones that we've talked about in our lectures, they're all free for alls. They could be on tests. Make sure that you're looking up your COPD medications. You can actually go to rxlist.com and look those up and look up either in your drug book or on rxlist.com for your side effects and nursing interventions. Agents to help cough up mucus, those are your mucolytics or expectorants like wifenicin. Those help to make mucolytics help make the mucus thinner so it can be coughed out. Expectorants cause us to cough more. And then, of course, cough suppressants cut down on the coughs. So sometimes we are combating both ends. um, we want to make certain that if it has guaifenesin in it, that's your expectorant. That's what it's going to actually cause the person's cough to be more effective. And then we have antimicrobials. Those are all of our uh, um, products, such as antibiotics, that help kill um, our bacteria. Now, again, antimicrobials do not work on viruses; those work on bacteria. So those things like doxycycline, levothyrox. Oh, excuse me. I'm trying to think of the other one. Well, I'll go on. It'll come back to me in a moment here. Uh, Look at your antibiotics. They're specific for pneumonia. That's the ones I want you to be able to key on because those are our first line products. Oxygen therapy, again, I've already stressed to you that oxygen is a medication. We can use it very sparingly without a doctor's order in order to help rescue or save a patient if they're having difficulty until we can get further direction from the doctor. So again, nasal cannula that is used to deliver 24% oxygen to 44% oxygen through the nose. Patient must be alert and not be mouth breathing. If they are mouth breathing, then that oxygen through the nasal cannula is not going to work because if they're not taking it through their mouth or through their nose. For greater oxygen needs, we need to be able to use a mask. So, patients whose pulmonary disease causes retention of carbon, again, such as COPD, should not use oxygen levels greater than 3 liters. And I stress this no greater than 3 liters because if we end up getting them on too much oxygen, then what happens is we shut down their CO2 drive. They don't breathe. So we need to be very, very aware of that. Now, I would write this one down. I would say COPD no more than 3. For patients who have low blood oxygen levels, again, oxygen becomes a stimulant to breathing. So their CO2 can actually lead their ability to breathe. So that's the reason why we don't want to overgive too much oxygen. Oxygen therapy is through a simple face mask, covers the patient's nose and mouth. This mask delivers 35% and 50% humidified oxygen at a flow rate from 6 to 12 liters. This is usually used for short-term therapy because it's uncomfortable. It's very claustrophobic. Um, then we have a partial or what we call a non-rebreather mask. These have a mask at the end that needs to be filled with oxygen at first, just partially filled. And then those can deliver higher rates, 60 to 90%. at flow rates of 10 to 15 liters per hour. So we can go all the way up. So I would base my information on what I'm giving you in this particular presentation because this is what will be on the test. So go back through and look at these notes, get down these levels. I'm going to run on down to, again, the Venturi masks. Those deliver precise high flow rates of humidified oxygen. That's a lightweight cone-shaped device that has little tubes that fit inside that actually deliver 24, 28, 31, 35, 40, and 50% oxygen. Again, if the doctor is precise and says, I want 35% or 40% of oxygen, then we use a Venturi mask so that we can control the mixture of air from outside in the room with a mixture of oxygen to deliver a precise level of oxygen. And of course, then we have our patients um, that are on ventilation, that a lot of times they will have them put on a Venturi mask over their vent, over their trach, because again, they're getting a very precise level of oxygen that way. Uh, our If you've ever been in the emergency room caring for a patient or seen or been with a patient that has acute disorder for breathing, sometimes the nurse will put in a nasopharyngeal or an oropharyngeal airway. That's a device that goes into the nose or into the mouth that helps keep the airway patent and open so that we can make sure that we can give high flow oxygen rates. Those need to be monitored very continuously because of the need. They may also use CPAP or BiPAP for those patients, and those masks have to be fitted correctly. They have to be on correctly. Otherwise, you can not give appropriate oxygen levels, or you can also suffocate them if they're not put on correctly because you're not delivering the oxygen appropriately. Chest physiotherapy and postural drainage, that's actually a way of loosening secretions in the lower airway. We use a cupping and clapping um, um, with our hands in order to break that up. I don't know if you've ever seen that. It's a very uh, it's a way that we use for cystic fibrosis patients in order to break up their secretions. They will get the physiotherapy that we actually have trained parents on how to do that with their children. There are now also devices that do that by just laying it onto the chest and it does it automatically. The patient should be in a head down with their on their left and right side, and basically prone, supine and prone. They'll have head down front. They'll do it on the front of the chest, and then they'll turn over and do it prone and do it on the back of the chest in order to use gravity to remove those secretions. You could actually see one of those being done under physiotherapy on the internet. There are a number of invasive therapeutic interventions the nurse can help with, such as chest tubes. We will making sure that we monitor the dressing around the tubes, make sure that they're in the same position, that they've not migrated out, that we need to make sure that we're draining and noting the drainage and the collection amounts. Thoracentesis is a process where we put a needle into the lung in order to draw out any of the fluid that is there. Bronchoscopy is actually a procedure where a tube is put down the person's trachea or through the throat or the nose into the trachea so that we can visualize the airway. They can actually take samples for biopsy, and they can also suction mucus plugs away from the airway and then also reopen those airways. They also use them with lasers, electrocautery or cryotherapy, and they can also put stents through those bronchoscopes. Nutritional therapy, that is therapy to be ensure adequate nutrition, high protein, high calorie, depending on their ability with their kidneys. Nutritious foods are important to these patients. And again, positioning two positions are important interventions, making sure that we put the patient high Fowlers as soon as we see that they have gas exchange issues. If that patient is laying flat, get them upright. If they're semi upright, then get them up into a higher Fowler's, get them setting up upright because that helps expand the lungs, helps them breathe a little bit better. Then we can then do our next intervention, which might be stopping fluids or obtaining or further orders or putting on oxygen. So the second position, there is another position that we can sometimes put patients in. The patients may be in a tripod position for COPD, which is basically leaning forward over a table. The second position is lying horizontally for those COPD patients, which especially left side, they may on the left side be able to distribute their pulmonary capillary blood flow, and whichever side allows them to be better perfused, whichever gives them better relief of their shortness of breath. So here's COPD. COPD is a chronic condition. It's um, chronic bronchitis, and then of course we hear about emphysema. Emphysema is actually the damage of the alveoli, and it's an umbrella term, of course, because it basically includes a wide range of progressive lung diseases that include emphysema, chronic bronchitis, and sometimes people with COPD also have asthma. Giddens, page 325, covers COPD, so make sure that you've reviewed that. A significant amount of work and breathing is expended by the person with COPD, so they're always tired. They can't do a lot of things very quickly. They need to space things out over time. It may take them a while to get dressed. Um, they have decreased muscle strength because of their deconditioning, and they don't have any endurance. They get very easily fatigued and have a hard time sometimes sleeping. Again, a lot of them sleep upright, recliners, or a few pillows because that helps. And of course, they have a reduced ability to accomplish their activities of daily living. Sometimes we need to help them put their shoes and socks on because it's hard for them to breathe and get down there to do that. COPD is most often caused by long-term exposure to irritants such as smoke, fumes, dust, or chemicals. The most common cause, of course, is cigarette smoking. Emphysema and chronic bronchitis are the two most common types of COPD. Together, they account for the majority. So here's a patient with our COPD, chronic airflow limitation. Again, here's a picture of him. You're going to see him in the tripod position. Here he is sitting, leaning forward, frequent respiratory infections. He's using his accessory muscles to breathe. He has orthopnea, where if he lays flat, he can't breathe. Dysrhythmias, they some may have bradycardia, they may have tachycardia, they may have heart block, other types of heart issues. So it's very interesting is because they come with a boatload of things. They're not when with a COPD patient, it's not just COPD. Cor pulmonale is actually a late disease. That is a disease that affects their whole chest, lungs, etc. So we're going to see these people having trouble catching their breath, especially during physical activities. They're going to wheeze a lot and whistle a lot. They may have a cough. A lot of times their cough will have clear white mucus, but when they're having problems with infection, it may turn yellow or green. They'll have tightness of the chest or feel heaviness, very lack of energy. They'll be losing weight without meaning to. That's one because they don't eat very much. They get take a few bites and they can't eat because they're just so tired or they get so short of breath. They will have swelling in their ankles from feet, so you'll see other also findings with their assessment. They are likely to have their symptoms worse um, when they're day to day with day to day variations. Sometimes the morning can be their better time or it can be their worst time. Um, Again, they can have exacerbations. That means that their symptoms are worse at some points, and they can tell this. They can tell you, "I'm having an exacerbation. I think I need something for," and they get to where they can't even talk. While they're talking with you, they get short of breath. Um, Certain triggers of smells or cold air, if they hit cold air, and they can get, spasms in their lungs, and they can have difficulty breathing. So with the chest tightness and the coughing more and increased in sputum, then we know that they're having some really bad problems. We'll see some drops in their oxygen saturation. Again, we'll see wheezing, pursed lip breathing, chronic cough, barrel chest, dyspnea, sometimes with increased rate or tachypnea. And of course, bronchitis, we'll see increased sputum. And then you may see, because they've had problems with their breathing for so long, they'll have clubbing of their fingers and nail beds. And I thought it was interesting that they chose a picture with a person using oxygen and a cigarette that's lit because there's smoke coming up from it. Very, very, um, well, unfortunately, we should make sure that they do not smoke and use their oxygen at the same time. What is the difference between acute and chronic bronchitis? So acute bronchitis, that's an acute condition. That means that's happening now. It's not something they've had before. That could be a cold, it could be a virus, it could be a bronchitis is inflammation of the bronchiole. And sometimes it can be contagious because it's caused by a short-term infection. The infection can spread through the mucus droplets and discharge when they cough or sneeze. Chronic bronchitis, on the other hand, is lasting over 3 months or more. And it's a lung condition that destroys the cilia in our airways and causes inflammation in the lining of the bronchi. The inflammation prevents good airflow. It's not contagious because it's not caused by an infection, it's caused by inflammation. So that's the result of smoking or some other irritant that has been of long-term duration. So causes, again, if it's viral, then viruses account for 85 to 95%. Those cannot be treated with an antibiotic. Everybody wants to have an antibiotic for a viral infection. And a lot of times we need to give them Tamiflu or check to see if they have the flu instead and treat them with Tamiflu or some other type of antiviral. If it's a bacterial infection, then they're going to have sputum that's spreading forth. Now, if it's COPD, we automatically treat them with doxycycline typically, and then some prednisone. And that, and then if it's due to irritants, we try to get rid of the irritants. We may give a Medrol dose pack if they're having inflammation with that in order to cut down. If it's asthma or also COPD, we're going to use inhalers in order to decrease inflammation and open up the bronchial airways. There's also infections caused by Mycoplasma pneumonia, also chlamydia pneumonia in children and adults, Bordetella pertussis. Now, Bordetella pertussis is whooping cough. If you've ever heard of a child having whooping cough, you've only have to hear that cough once to have known, oh, that's whooping cough. Breathing in irritants again, such as smoke, fog, smog, chemical fumes in your trachea or bronchial tubes can lead to acute bronchitis. Patients with asthma will sometimes develop acute bronchitis as well, and it isn't likely to be contagious because it's not caused by, again, by an infection. Typically, it's from air or cold air, and then it's stimulating their asthma, eosinophil, and histamine reactions. Risk factors, again, cigarette smoke, if they have illnesses that weaken the immune system, secondhand smoke, gastric reflux, and of course, vaccinations or the lack of vaccination. A productive cough is the most common symptom of acute bronchitis, and that can last anywhere between 10 to 3 weeks. Another symptom that we need to note is what is the color of your mucus? Is it green or yellow? This doesn't mean that it's caused by an infectum. It just means that your immune system is working. So your white blood cells get into kick. They get in there. They surround that mucus. They surround that foreign material, and it cuts down on the bacteria. Um, if a patient is having difficulty with their breathing, definitely they should need to be going into the emergency room and especially if they have a unexplained weight loss, a deep coughing bark cough, where they have fever of 100 degrees or higher, or if the cough is lasting more than 10 days, they definitely need to be seen by their physician or go to the emergency room so that they can get treated. Most COPD patients stay into close contact with their providers, and a lot of them have what they call a rescue pack. A rescue pack is a medication that they already have on order that they can obtain prednisone, if necessary, doxycycline, and then, of course, to make sure they have plenty of refills on their nebulizer and their bronchial dilator medications. So, our bronchitis diagnosis and treatment, we're going to be listening to them, we're going to be taking their assessment. We're going to do an X-ray, take a look at their lungs, make sure that there's no atelectasis, which is collapsing, and make sure that they're not filled with fluid, or we can usually see with the X-ray whether or not that this is truly a uh, issue of the chest, and that's not just viral, that it's also bacterial. We may have to do a sputum test. They may ask for a sputum to be collected to be sent off for culture and sensitivity. And then we may also be doing blood tests or other type of blood cultures. So what is the treatment? Unless your symptoms are severe, there's not a lot that your doctor can do to treat acute bronchitis. Usually we give a little Ventolin or, again, bronchodilator. They may give some Pulmicort or something to open up the airways. We'll tell you to take Tylenol for your discomfort, maybe something for your cough is over the counter, some guaifenesin, Mucinex, but to allow it to go ahead and do its thing. Usually it's very self-limiting, and it gets, cured on its own. But if you are at higher risk for developing bacterial pneumonia or bacterial problems such as COPD, then they will probably prescribe something more over the counter, not over the counter, but go ahead and give you the antibiotics and things. We're going to tell you to take nonsteroidal anti-inflammatories such as ibuprofen, Advil, naproxen, or Aleve that may soothe your sore throat, to use cough drops, etc., to get a humidifier to moisten the air, to drink plenty of liquids and fluids, teas to thin the mucus. I love to take peppermint tea, or what they call cold remedy tea, because it helps loosen that up, helps soothe, and to add ginger to the tea for your stomach as well as anti-inflammatory. It helps coat the inflamed bronchial tubes and helps calm them. Of course, honey also is very soothing, and is great to help with wheezing and soothing the throat and the cough. So there's a lot of things we can do that don't require medications, or I should say prescription medications. So here's chronic bronchitis. The air tubes are narrowed as a result of our tissues and excessive mucus production. The whole idea is to keep that mucus out of there, keep it from turning into bacterial infection, and of course, we're going to be watching for increased fatigue and low-grade fever. Pulmonary function test is a test that we can do with patients to check to see what their pulmonary capacity is, to check that airflow. It requires the patient to do a number of maneuvers where they will breathe all the way in as much as they can. They'll put a clamp over their nose and they breathe as hard as they can, and they keep on breathing, breathing, breathing until they empty their lungs. And we basically look at the capacity of the lungs. Um, We again will tell patients that if you smoke, don't smoke before you go in. There's no smoking, no using deodorants or using those things. They should go ahead and take their bronchodilator in with them. They want to first do their first test with PFTs without the bronchodilator to get their worst case scenario of their lungs. And then they'll take their medications and then they'll see what the best case with the medications. Do they have reversibility with their medications? Again, steroids may be prescribed, corticosteroids. And then there's also pulmonary rehabilitation, just like cardiac rehabilitation. Those are exercises to help a person breathe better. Oxygen therapy and antibiotics, again, our last resort if we think the person needs it. We've been using antibiotics too much and overprescribing. Emphysema, the main cause again is breathing and using or being around too much smoke and air pollutants and pollutant factors. It can be partially genetic as well. Cigarettes destroy the lung tissue, causes damage to the cilia. It keeps us from being able to keep our airways clean and clear. And eventually, the first signs of emphysema is usually not noticed until 50% or more of their lung tissue has been destroyed. So it's a gradual shortness of breath and an increased work of breathing, especially noted when they're climbing stairs. We can tell emphysema, of course, with CT and can assume it when we see the X-rays. There is the Global Initiative for Chronic Obstructive Lung Disease. That's the GOLD. That's a great go ahead and look that up. It's the GOLD for COPD. And it describes the stages of emphysema and COPD and also provides healthcare providers such as nurse practitioners and doctors with the strategies of how to treat this from stage 1 all the way to stage 4 and what we should be doing. Again, review stage 1 is the mild disease. We got 80% of the lungs working, but then in stage 2, that's 50 to 79%. Stage 3 is when 30% to 49% is no longer working, and then less than 30 in stage 4. And so it's a stepped treatment plan that has been proved by research, and it tells us exactly what therapies we should be using at what stage. The management of COPD and emphysemas, again, bronchodilators, corticosteroids, antibiotics, anti-inflammatories. Again, that's your NSAIDs and prednisones, etc., corticosteroids, oxygen therapy, and of course, end stage is lung transplant. You have to be not smoking to be on the lung transplant list, and you have to be not smoking for a while. So there's also a procedure that they can do besides that one. It's called lung volume reduction surgery. Sometimes they'll remove a part of the lung tissue that is damaged so that they can help improve the remaining part of your lung tissue to help it stretch out and to be able to breathe. Not all people with emphysema, though, are candidates for that procedure. There's also a bronchoscopic lung volume reduction, which is a smaller area that they're just trying to get rid of that area that's causing trapping of air. And of course, lung transplant, that's a pretty severe condition and treatment. It replaces the damaged lungs with a donor healthy lung. And your severity of disease and expectation on outlook. If they have emphysema, depending on what stage they're at, definitely they should be in palliative care. That way they're receiving the assistance they need, and they need to understand they need to stop smoking. I've had patients say, "Oh, I've already done the damage. I'm not going to stop now." But the death in COPD and emphysema is very uncomfortable. It's very uncomfortable to watch. And to be a part of that. And it is just a very sad ending for a life that could have been, of course, prevented. Asthma, is an autoimmune disorder. Again, we're looking at eosinophils sometimes with that, and we're also looking at other um, causes of airway obstruction. It's a hyper-responsive to stimuli. Sometimes these patients can have asthma attacks due to perfumes and smells that, people spray aerosols or they use these deodorants and stuff that have high smells, and the person next to them may have asthma and it triggers an asthma reaction with them. So they'll have wheezing and coughing, dyspnea, and a tight chest. And the tight chest, of course, is caused because of the inflammation that's involved. It can be genetic. And the symptoms again, wheezing, whistling sound when breathing, coughing, and very tightness and short of breath, feeling out of breath. Asthma treatment again is some of the same medications, avoiding triggers, monitoring, and lifestyle changes. So we do a lot of teaching with our children that have asthma. Sometimes they can have sports-induced asthma. We'll tell them to use their inhalers and stuff and try to avoid triggers, to use those ahead of time so that they can feel well. The prevalence is higher among females for asthma ages 20 to 24, and multi-race and American Indian or Alaska Native persons are higher with asthma. Among children, the prevalence is higher among males ages 5 to 14. And there's multi-race and people of Black descent. So we're talking African American as well. Our medications include inhalers, bronchodilators, corticosteroids to relieve inflammation and to prevent attacks. We tell them to avoid triggers, so avoid the allergens or irritants that can worsen your signs and symptoms, to monitor themselves and to come in for their well child or their normal uh, checkups. That most of these kids do go to a pediatric pulmonologist to be seen at least on an annual basis. So, pneumonia etiology. Pneumonia is a lung disease. We characterize that by inflammation in terminal bronchioles and alveoli of the lungs. It can be caused by viruses, bacteria, fungi, and atypical organisms. Organisms that most frequently cause that are good. Um, Excuse me, I needed to cough there. Uh, those the organisms that I'm talking about again are the pneumoniae, the Klebsiella, the mycoplasmas, the different things of that sort, and then of course we see a lot of viral pneumonias that affect all ages. So pneumonia, it's obstruction of the bronchioles. People can't breathe because of decreased gas exchange due to the mucus that is trapped into the lungs and the alveoli. They're going to have symptoms of cough, fever, chills, tachycardia, tachypnea. Tachypnea is a fast breathing rate. It's usually characterized when they get to a respiration rate of around 28 to 30-ish and above. Dyspnea, shortness of breath, chest pain, malaise, respiratory disease, and breath sounds are going to be really crappy. They're going to have a yellow productive or bloodstream rust sputum. If it's rusty, then we know that those are caused by more bacteria. Opportunistic is your pneumocystitis, pneumonia, mycobacterium again, avium complex or MAC. Should you wear a mask if you were with a patient that, yeah, if they're in droplet precautions, yes, you put on a mask. Don't just go in there and put yourself at risk, especially if they're coughing. Again, if they have pneumonia that is of a infectious nature, they're coughing those little bugs out of their mouth and sneezing them, and yes, you can get that too. So make sure that you're wearing your mask. If they're in droplet precautions, a mask is required for you to be near them. Now, your doctor's orders are going to include things like a sputum culture, chest x-rays, maybe arterial blood gas, so that we can make sure that they're not having issues with respiratory acidosis by holding on to too much CO2 because they are breathing low and slow. So again, chest x-ray, ABG, sputum culture, CBC. Neutrophils will be increased with their white blood cell count. Hemoglobin, if they have anemia, may be lower, and that is going to increase their shortness of breath if they also have anemia. Their platelet count being different may indicate inflammation or infection. We are going to also be checking a basic metabolic panel, check their sodium, potassium, but due to dehydration, we're going to look at the BUN and creatinine, maybe to make sure the kidneys are functioning. Look at their glucose levels because if they're receiving some type of prednisone or corticosteroid, that's going to increase their glucose. And of course, CO2 is going to tell us whether or not they're in acid-base imbalance. Are they holding on to too much CO2? So our patient teaching is to make sure that they have follow-up appointments to take their full course of antibiotics that they've been prescribed. If they have 14 days of antibiotics, please take all of them. Don't just stop because you feel better. Wash their hands frequently, get their pneumonia vaccine, get their flu shot. And if they do not do this, yes, prognosis can be treated, but pneumonia is very fatal. About 20% of Americans die from pneumonia every winter season. Patients that are going to be at worse uh, treatment outcomes are going to be those that are requiring oxygen therapy. They're having more secretions. They may need to be suctioned if they are having difficulty, if they're having cough and deep breathing issues. We need to make sure that they stay hydrated. If they're on mechanical ventilation, we need to assess them quite often, make sure that we're getting them suctioned and using sterile technique to take care of those suctioning and the trach care. Again, proper hand hygiene is always good. Make sure that we disinfect the surfaces, that we tell them not to smoke, put some nicotine patches on them if they are a smoker, and to provide supportive care such as adequate oxygenation, hydration, and pulmonary hygiene, which means having them cough and get that stuff out of their lungs. Again, antibiotics, antivirals for viral pneumonia, and antifungals if appropriate. And these patients may be at droplet isolation if they're infected again. Our nursing interventions for patients who have pneumonia is respiratory management, of course, monitoring oxygen levels, practicing strict asepsis, making sure that we're washing hands, preventative measures, supportive care, providing patient care, education, making sure that they're doing their cough, deep breathing techniques, and watching for any signs and symptoms and documenting any changes in their vital signs. Here is a YouTube that I'll have you watch on your own on anemia. Of course, it's talking about blood cells and what are the causes of anemia and pernicious anemia. Think quick, what is the link between oxygen and anemia? Okay, that's your oxygen and hemoglobin. Low hemoglobin means you can't carry oxygen. So if they have low oxygen and they're anemic, we've got a problem because we don't have enough oxygen that is being transported by the hemoglobin to get to our end cells. What are our diagnostic tests for anemia? It's going to be our complete blood cell count, iron studies, hemoglobin, electrophoresis, blood smears, where we actually, that's a part of the lab where they actually look at the formation and look at the blood morphology. Is the blood cells normal? Targeted deletion analysis, bone marrow function assessment, vitamin level assessment, and then we'll look at their bilirubin genetic testing, targeted molecular studies, and blood type and antibodies. So iron studies, that's our serum iron, ferritin levels, transferrin, saturation, and free electrolyte, or FEP testing. Specialized testing is our hemoglobin electrophoresis. That's for thalassemias. Those are blood disorders. So if they have an alpha thalassemia issue, then they're going to be identifying that as part of a genetic. Those people don't carry enough hemoglobin. Vitamin level analysis. We need to look at the vitamin B12, their folate, and the methylmalonic acid levels. Additional tests is bilirubin, genetic testing, blood type, and antibody testing. Do they have sickle cell? That's what we're looking at. Anemia types, a number of different types. We need to identify and treat the underlying cause because there's all different kinds of cause. If it's due to iron deficiency, then we're going to treat the iron. If it's because they have a low hemoglobin, we're going to figure out how to get the hemoglobin back up. Is it vitamin B12? Is it vitamin B12 deficiency? Do they need vitamin B12 infusions? We're going to look at blood counts, we're going to prevent complications, we're going to provide oxygenation and the types of issues that they may be having with their anemia. Inflammation, of course, is part of the problem with anemia as well. And it could be that they have an autoimmune hemolytic anemia. That's where the immune system attacks the red blood cells and kills them off before their time. Of course, we've talked about vitamin B12 deficiency. If they need vitamin B12, we give them that. Um, Hemolytic anemias that could be due to sickle cell or G6PD deficiency or hereditary spherocytosis, which again is a change in the morphology of the red blood cell. It can be also that we have some causes that are mechanical trauma, maybe that it was due to dialysis or due to blood transfusions. Of course, sickle cell anemia, we know it's a painful end organ fatigue type condition, and it causes those cells to become sticky and they block the small capillaries, causing pain. Aplastic anemia is severe fatigue, infectious, uncontrolled bleeding. That particular treatment for aplastic anemia is blood transfusion and stem cell transplant. And then thalassemia, again, this is a condition where your body produces less hemoglobin, resulting in red cell, blood cell, and anemia. Treatment for that is monitoring blood transfusions, etc. And then we have macrocytic and megablastic anemia. Make sure you review these different types of anemia and your reading and that you know which ones. Now, one of the ones that can be prevented, of course, is iron-rich food anemia or iron anemia. So if we make sure that the patient is getting plenty of iron in their foods. So here's our questions area. Here's the NCLEX review questions. A nurse is analyzing arterial blood gas result for a patient. Which parameter directly indicates the patient's oxygenation status? Again, which one is our oxygen? Okay, our answer is going to be C. That's our PaO2. That specifically measures partial pressure of oxygen. The nurse is assessing a patient with COPD who reports increasing resulting daily activities. Which clinical manifestation would the nurse most likely observe first in this patient? So our COPD patient, our first probably, now it's not going to be dyspnea at rest because that patient, if they're at rest, may not be showing any type of symptom. Now, we may note the barrel chest. We may see some weight loss. A lot of these patients are also heavy. So the first one actually is intermittent cough. That cough is intermittent. It's typically the first sign and is the first warning sign that these patients have that they are having a problem. A nurse is assessing a patient with anemia. Which clinical manifestation is likely to appear first in a patient? Of course, that is going to be mild fatigue during exertion. When anemia develops gradually, the body can initially compensate for it, but the first noticeable system or symptom with these patients is that with anemia is that they can't do as all of a sudden they note that they can't do as much as they once did. So they're having more issues, dyspnea at rest, acute pain. The nurse is caring for a patient with a pH of 7.32. First of all, is that a normal pH? What is our normal range? Which statement best describes this patient's acid-base status? So we're only talking about the pH. I'm not asking you whether or not they're in respiratory or metabolic state. It should be that the patient Is this normal? No, it's not C, so we know it's not C. Nope, it's going to be B, acidemia. The patient has an acid blood level. That's what acidemia means. Acid is in the blood. A nurse is assessing a patient with suspected pneumonia. Which clinical manifestation is the most reliable indicator that would support this diagnosis? Well, when we're listening to that patient, we're going to be hearing a productive cough, and they're going to be hearing some crackles, may hear some bronchitis, they're going to have some fever. So if they have congestion and stuff in that, it depends on how much congestion is there. If they have a lot, it's going to be a lot of rumbling going on. The presence of crackles or fine crackles are also typically what we hear with congestive heart failure with water. Uh, I would have probably said uh, more rhonchi, but if we have any type of adventitious lung sounds, we should suspect and put all the picture together. So, do they have a cough? Do they have a fever? Is it productive? Okay, this possibly could be pneumonia. A nurse is assessing a patient with impaired gas exchange. Which combination of clinical manifestations would most likely indicate a deteriorating condition? Well, mild anxiety and slight shortness of breath are not going to be very concerning to us. I mean, because it's fairly normal if they have mild exchange. Occasional cough and normal respiratory rate, no, that could just be a cold. Clear lung sounds and normal skin color, no, that's a normal assessment. So the only one left is B, which is tachycardia, dyspnea, restlessness, and increased CO2 levels. Yes, we would be definitely saying, oh, we've got a problem because if they're holding on to CO2, that means that they're not being able to blow off. The CO2 is normal. They're retaining because they're low and slow with their breathing. Therefore, they're retaining. And so they're going to eventually be in what condition? Yeah, if you said respiratory acidosis, that is true because if they're retaining on CO2, then we're talking respiratory acidosis. Here's another one. A patient asked the nurse, what should I expect during my pulmonary function test? Okay, pulmonary function tests require participation from the person. We would tell them you'll breathe into a mouthpiece, take the deepest breath possible, then exhale. Exhale as hard and fast as you can until they tell you you're done. You need to go, 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 go. So that would be B. Diagnosed with acute bronchitis, which statement of the nurse regarding antibiotic therapy is most accurate? Again, as I said a couple of times, antibiotics have been overly prescribed. That's the reason why we're having trouble treating a lot of things when people get severely ill. So we try not to give patients antibiotics just because they may have bronchitis. We try to treat that with supportive care. So B is that antibiotics are only indicated if the bronchitis is confirmed to be bacterial. Um, Again, we're just wasting the cost of the antibiotic and causing the person not to be able to be treated later if they need a bacteria or if they have a bacteria. If we're giving an antibiotic too soon, they become antibiotic insensitive. A nurse is caring for a patient with emphysema. Which assessment finding would most be characteristic of this condition? Yeah, barrel chest with pursed lip breathing. Their chest wall eventually changes because there's so much damage to the alveoli and the lung tissue. Okay, I'm going to just have you consider this. Mrs. Jones is a newly diagnosed with asthma and seems hesitant about taking their controller medications when he feels well. How would you explain the importance of medication adherence to them? Well, the key here is to tell them that the controller is not just to control when they're having symptoms, it's to control to keep them from having symptoms. If they don't take their medications as prescribed, then they may end up having exacerbations that could have been Basically, exacerbations could have been avoided. We don't want them to have any exacerbations, and we don't want them to having any symptoms. So, very important for them to continue to take the medication even when they feel well, because that's keeping them well. Thank you so much for your time. Consider this information. Go back and review your information in your books. Make sure that you're looking at SurePath. I will be posting this on SurePath. So thank you so much for your time and consideration, and I wish you well for today.